Good afternoon, everyone, and I would also like to express my thanks for being a part of this panel. So my job is to tell you more specifically about the Apollo study, with Dr. Friedman having laid the foundation talking about the APOL1 gene. So this is a study sponsored by the National Institutes of Health to look at long-term outcomes in those APOL1 long-term transplantation outcomes. And this network is going to do three things. Look at the impact of the risk variants, and I'll go into those in a little bit, in the APOL1 gene on the outcomes for the kidneys that come from donors with recent African ancestry. And I define recent African ancestry at the bottom, meaning self-reported African Americans, Hispanic Blacks, Afro-Caribbeans, and Africans. We're also going to look at the recipients of those kidneys and look at living kidney donors of African American recent ancestry. So that's the what we're going to be doing, and this is a little bit more information about how we're going to be doing that. So we're going to prospectively, meaning we're going to look forward at kidneys that are transplanted at the time they're transplanted, and then follow the donors, follow the kidney from deceased and living donors going forward over several years. We're going to look at the transplants themselves, the donors, the recipients, and do genotyping, meaning we're going to look at which APOL1 variants the donor and the recipient carry. And in that way, we'll be able to assess what the effect of those genotypes are on the longevity of the kidneys. We're hoping, as Dr. Friedman pointed out, that the results will help some revision of that formula that he showed you, the KDRI, and replace race with genotype, which would be much more accurate and is actually biologic. We further hope that this will lessen the discard of good quality kidneys. So we're hoping this will inform policies and guidelines also for living donors so that people will know if they're at increased risk if they donate a kidney. So this shows our organizational chart that it's across the entire U.S. Our hope was to engage all of the transplant programs in the United States. We haven't fully realized that, but we have the majority of the transplant programs. This is funded by three of the institutes at the National Institute of Health, the National Institute of Diabetes, Digestive, and Kidney Diseases, National Institute of Minority Health and Health Disparities, and the National Institute of Allergy and Infectious Diseases. You can see we have our Community Advisory Council, which you will hear a lot more about shortly, the Executive Committee and Steering Committee. We have an external expert panel that kind of acts as our guiding light and advises the NIH on things that we should be doing. And Wake Forest, you've learned, is our scientific and data research center. This also required partnership with United Network for Organ Sharing, the Association of Organ Procurement Organizations, the American Society for Histocompatibility and Immunogenetics, and the genotyping labs, as well as the NIDDK repository. So what's the rationale for this study? It's going to be the first prospective assessment, meaning, like I said, looking forward. The study that Dr. Friedman described was looking back at, here are people that received a kidney, now let's go back and see what their status was. Here we're going to be following them going forward. And this will be the first large study to look at the effect of the donor and recipient. The data that we have from the retrospective studies seem to indicate that it's only the donor genotype that's driving this, but we don't know with absolute certainty that that's the case, so we're going to look at both. And there's just not a lot of data out there on the safety of living donor donation in African Americans based on their APOL1 genotype. So we're looking at the time to kidney transplant failure. That's the primary outcome of this study. And it's going to be based on the number of risk variants. We're going to talk about the variants a little bit more in a second. And we're also going to look at the rate of loss. So not just does the transplant fail, how quickly does it fail? What's the rate of change in the serum creatinine concentration, a marker of kidney function, likely well known to people on this call? And the time to development of proteinuria, since protein in your urine can sometimes be the earliest sign of kidney disease. So let's go back and talk a little bit more about kidney health and look at things here that influence not just kidney health, but your health overall. Healthy diet, exercise, not smoking, limiting your alcohol intake, and getting checkups. Those are things over which we have control. But a big component of health is our genes. And of course, we have zero control over that. We inherit these from our parents, and the differences in some genes can put us at risk for different diseases. In the case of ApoL1, it puts you at risk for kidney disease. There are three forms of the ApoL1 gene, G0, G1, and G2. And like all genes, you inherit two copies. You have one copy that you inherit from your mother, one copy from your father. The G0 is the most common, and there's no increased risk of kidney disease if you have two G0 genes. The two that can cause an increase in risk of kidney disease are G1 and G2. And as you can see from this graphic, if you have only one of the risk variants, G1 or G2, paired with a G0, you're at no increased risk for kidney disease. You're simply a carrier. You can, however, pass that higher risk gene on to your children. Where we see the increased risk for kidney disease is in people who have two copies of G1, two copies of G2, or one copy each of G1 and G2. It's important to point out, though, that 4 out of 5 people, or 80% of people, even if they have two copies of the higher risk forms, will not get kidney disease. So this is not, there shouldn't be doom and gloom that you find out you've got two risk variants and you think that you're absolutely going to get kidney disease. That is not the case, but it does increase the risk. And there's a lot of other research going on in terms of other things that pair with that cause you to have kidney disease. So the Apollo study is here to try and improve the lives of people that are donating or receiving kidney by trying to learn more about these risk variants and the impact that they may have. So again, we're going to look at the genotype or the variants in the kidney donors and in the kidney recipients to see when these two are melded, is there an increased risk? So this is my final slide. The study is being conducted by kidney doctors and surgeons. The Community Advisory Council all came together and designed this study. The Community Advisory Council, you've probably heard already, but we'll certainly hear a lot more, is a group of kidney donors and recipients or relatives of people who have chronic kidney disease or end-stage kidney disease, and therefore are more likely to have high-risk forms of the ApoL1 gene. We really want to point out that people who donate or receive a kidney and participate in this study are going to get the same medical care they would whether or not they were in Apollo. It requires just a small amount of blood and urine. We'll find out what form of the ApoL1 gene they have, and we'll see how they do over many years. So we come back to our why for this study, and that's to improve the lives of those who donate or receive a kidney.